Bismillahirrahmanirrahim. Assalamu alaikum and good morning everyone. I welcome you all to the Emergency Medicine Grand Run on behalf of the Office of Academics Maroof International Hospital. Those of you who are joining us online, thank you very much. I would just like to humbly request you to keep your mics muted. And if you have any questions, you can raise your hands towards the end and we'll be happy to answer your questions. So the ongoing COVID-19 pandemic has been an epic test of character and motivation for millions of people around the world. But nothing compares to the sacrifices the frontline healthcare workers have given and the extraordinary demands and challenges the hospital had to face and cope with. Leadership hospital has been fortunate enough to have Dr. Mir Abdul Waheed as our leadership. He is the director of Maroof International Hospital and also the head of the emergency department. Dr. Mir has been a tremendous support and has led this hospital with great integrity throughout this difficult time. And College of Surgeons, Edinburgh. Going to be sharing with us his experiences based on COVID-19. Please bring Dr. Mir Abdul Waheed to the podium.
Thank you, Shmail. Today I'm going to talk about our experience in Maroof International Hospital and indeed something about the journey which has taken all of us and the whole world by surprise, and we didn't know what was right and what was wrong. And actually it's also a tale of human resilience and healthcare workers rising to the challenges and sacrificing their lives to save the patients. I would like to start by having some timeline details and present some COVID stats. How did we come about in our own first, and at the end we'll talk about some vaccine and the last thing,
you have to mute the mic.
Please people are not able to mute their mics, please. And in the end, we'll talk about the question everybody's asking, is the end in sight? So I think very few of us would ever have read this news, which was a two-liner in New York Times, and I'm sure appeared in all the newspapers around the world that China had reported that they were treating cases of some pneumonia, typical pneumonia in Wuhan, China. This is on 31st of December. I don't think anybody noticed that this was something which will become the headline for the rest of the year. And it was after about 11 days that China first reported their first known death from the COVID, from the pneumonia which was being treated and not named as such at the time. January 20 was the time when first cases were reported outside China, including Japan, South Korea, and Thailand. WHO declares World Health Emergency on the January 30th, 2020, and this was the time that all the world was now counting on that when is their time. And I think this was February 2020 that we first had report a case of COVID in Karachi, and the same day one case was reported from Islamabad. So the 26th of February was the day that we were embarrassing ourselves, and then the news came that this patient had actually come from Iran, and he'd gone there, and Iran, if you remember at the time, was having a huge wave of cases. So this was from Karachi. And then the second case, which was reported in Islamabad, that lady had visited from the UK. So that was the start of COVID in Pakistan, 26th of February. So this is from the dashboard, the official dashboard of the government of Pakistan from the 1st of October yesterday. And you can see that so far we have about 312 cases. Out of this, we have about 6,484 deaths. The last 24 hours, we had 5 deaths, and 2.1% is the mortality rate. This was the daily tests and new cases, and you can see that from March onwards, it has slowly started to rise, and we saw the peak in May to June, and then it starts to decline again with slight up and down. The last, on the 27th of September, these are the new cases which we have. Currently, at the moment, the positivity rate is about 1.58%, and number of tests, we have almost reached about 34 to 35,000 tests a day, which is the highest so far in this epidemic. This is for Islamabad. You can still see that the number of cases starting from, this is in September, you see 12, 16, and then dipping again, and then rising, and then going down, and then at 30 cases. Yesterday, on the 30th of September, we have got 30 new cases in Islamabad. Moving on, this is the John Hopkins, I think the most trustable resource so far around for the global numbers, and you can see about 33 million people so far have been infected in the world, and the global deaths around more than 1 million. The highest number of cases in the US, and then India just falling behind with Brazil and Russia. This is what it is at the moment, the latest situation. Our response to this pandemic was like any other place where initially there was fear, fear of the unknown, because we didn't know what was coming and what the disease we were dealing with. There were so many things coming that we can try that, and then things about chloroquine and so many other things. But the initial fear was that because we didn't know that what was the disease like, so we all went into our shells and we tried to protect ourselves, and we basically started with issues of guidelines as early as February regarding hand washing, personal protective equipment, social distancing in place. We were actually caught by surprise with our first case, which we admitted in mid-March. This was actually a young girl we admitted with abdominal pain as a query appendicitis. Up until that time, the literature was saying that these patients usually present with flu-like symptoms, some sore throat, things like that. But actually, the reports had started to come a day before our patient admitted, that a few cases in the US have been reported with gastrointestinal symptoms, but none with abdominal pain. So this girl was admitted about 3 to 4 days, and on the fourth day when she was consulted for headache by a neurologist that he actually thought about COVID, we sent the test and it came positive. So this was something of a joy for us at the time, because we had about 23 of our staff who were exposed to this patient. But alhamdulillah, none of them tested positive for that. And we actually were appreciated by MIH, and they asked us for our policies as well that what we have implemented here. This was the time that we had heard about that all around in our sister hospitals there have been admitting patients with COVID and staff there, and one of the hospitals was actually full with their own staff and they had stopped taking the patients from the outside. Our response was to still wait and see, because actually personally I thought, and we have been discussing it every week, that it may be too much overwhelming, that how could we do it and can we do it. Meanwhile, patients continued to attend ER and were transferred elsewhere. Early May, as we saw in that graph, cases started to rise and we had a medical affairs meeting. There, after thorough discussion, we decided that we need to do something about it because we had been transferring patients outside the hospital and a couple of patients had died because there was no space outside to the place where they were referred. So we decided that we need to make a purpose-built facility where we should have elective section and an in-house ICU and ICU and dialysis facilities for those patients. A COVID task force was created, and which came up under the leadership of Dr. Waheed, our ICU consultant. We came up with a comprehensive compendium. The staff hiring was started, and we did training done before the opening of the COVID facility. So all the staff were actually trained, the nursing staff and the doctors, in PPEs and the basic infection control measures. This was something for a comprehensive document which we came up with. It's about 30-40 page document which listed everything from protocols from hand washing, PPEs, and clinical companion, a complete document. This was one of the risk stratification tools we adopted from Royal College of Surgeons for Emergency Medicine, and for our patients' risk stratification. And this was used in ER, and by using this tool, I will refer to in the next few slides as well, that this was the tool which actually decided who was to come in and who was to be discharged. Basically, somebody who was SATs less than 90, respiratory rate more than 30, a recalling score more than 7, and GCS less than 15 was something more serious, and then people who were having upsetting saturation of more than 94% on room air, and respiratory less than 20 were good to discharge. The facility was inaugurated on the 6th of June. We had about a total of 25 beds with 3 ICU and 2 HU beds and 2 dedicated dialysis beds in that facility. This was our first patient which was transferred via the ER, and you can see that he was fully covered with all the precautions. These were decided by the compendium that when the patient was decided they should be covered. So this was the first patient which was being transferred to that facility. Now, this is the data which we have shared with the government agencies throughout this epidemic from the 27th of March to the 31st of August. And this data is already shared with the agencies, and so that's what I'm presenting it here. We may not be able to go into the clinical details of so many other patients because that requires some IRB approval, and it's another research project in the pipeline, but this is the data which we have already shared. So the total number of patients who were seen in ER was about 138. We discharged them using that pathway which I showed you earlier. About 59 of them were discharged. We admitted about 79 patients to the hospital so far. Out of these, 42 were admitted in the dedicated COVID unit, and the 27 were the other patients who were admitted in main ICU. Out of the 42 we admitted in COVID unit, we had about 18 going to the ward and about 24 going into the ICU and HDU combined. These were predominantly males, and the age bracket was from 55 to 88 years. patients who went to the ICU, HDU, we gave TOSI was given to 5 patients, remdesivir to 5 patients. It became available in June. Only plasma was given to 2 patients. TOSI was given to about 5 patients and plasma. So about 7 patients got plasma in all. And TOSI and remdesivir, 1 patient got both of these. I don't have the details of these patients and their comorbidities and everything, because that, as I mentioned, is part of another research. We ventilated about 19 patients in all. Mortality among ventilated patients was 63%. And this is, I think, in line with the international, where you have about 50 to 60% mortality in ventilated patients. Our overall mortality so far is about 30%, and we have 24 patients who actually died from 79 we admitted in all. So the main presentation in our patients was shortness of breath in those who were actually admitted to the hospital. As I said, using that pathway, patients with low SADs and changes on HRCT were admitted. Out of the 59 patients, their major complaint was sore throat, fever, and SADs were above 94% when we discharged them. I think when the disease started, it was we were told that this is a flu-like symptom, but from our own experience, and we have seen in the patients that very few of them actually presented with flu-like symptoms, that you have a runny nose and blocked things. It's basically now, I think, that if you have sore throat with very bad body aches, that's probably the thing that straight away points to the COVID thing. Very few people actually, in our experience in ER and from the stats as well, that they actually had this runny nose and kind of stuffed nose. That was probably the way we described flu around that, but that was not the presentation what we saw. And that's probably also something which we need to consider going further. So 3 of our patients were admitted with gastrointestinal symptoms, diarrhea and vomiting-like symptoms, and then when COVID was sent, it was positive as well. And I mentioned about 1 case with abdominal pain, which was the first case, which was admitted as query appendicitis and then turned out to be COVID at the time. This is our data from the lab, month-wise, how many tests we have done so far. And you can see in April we did about 174 tests, and our positivity ratio was about 3%, which is rising to 14%, highest in June and July, and then starting to decrease again. We are currently at about 1%, and I showed you the national data, which is about 1.58%. So this correlates well with the downward trend. This is stats about our hospital staff infection. A total of 33 of our hospital staff was infected so far. But there was not a single case of any healthcare worker being infected in the COVID unit. So this was the unit which was dedicatedly open for the unit for this purpose. And there was not a single worker who was working there. We had about 40 people working in that unit in different shifts, right from the doctors, nurses, healthcare assistants, URs, and cleaning staff. And none of them was actually infected in that unit. And this is actually, I would say, thanks to Allah and also to the training they got at the start and the policies which were put in place, because we had reports of major outbreak among the healthcare workers in our sister hospitals. And also, this was the one fear which had led us hold back the opening of the ward all along because we were fearful that we may not be able to control the transmission to the staff, and instead of helping the patients, we may end up getting our own staff infected. So I think this is something we are thankful to Allah, and also I think this is because of the team effort of all staff involved that they took the guidelines very seriously. I do take note of Dr. Qadri's observation today that we have relaxed a bit, and I think we need to stay on the top of those things, and we will, inshallah, make sure that we stay on the top. When I say majority was community acquired, because we looked at all these 33 patients and looked at their, few of them were, about 14 were patients who were not people, the staff who were not actually connected with the patients themselves. They were from the lab or from our reception department and management and all those things. But out of the nursing and doctors as well, there was we looked at all those things and we could not pinpoint to one patient or a transmission where we could document that yes, this was the patient here which he was exposed to, and then he got it from there. But still, having said that, there were total 33 infected staff, and alhamdulillah, none of them required hospitalization, and they were all managed on home quarantine basis. This is the same slide about our test and positivity rate, which I've just mentioned, that in June we had done about 3,600 tests, and the positivity was 14%, which is down now to about 1%. Something about the vaccine now, that all of us are looking for vaccine and waiting for it actually to come so that we can begin our lives again. But as I will discuss in the next few slides, it's not that straightforward. At the moment, we have about 149 vaccines in preclinical trials, means they are being either developed or they are in the animal trial at the moment. And this is the biggest response humans have mounted against disease by so many people working to get a vaccine. Out of these 149, 16 are actually in the phase 1 trial and vaccine testing safety in dosages. 13 have moved on to the phase 2 and 8 in the phase 3. There is only one licensed by the government agency, and this is the Russian vaccine. But as I'll discuss there, that the Russian vaccine actually has not gone through the usual vaccine development cycles. For reminding ourselves that what is the phase 1 trial? The phase 1 is the trial where the vaccine is given to about 100 people to check its safety, and before moving on to the second phase, which is tested on the 700 people, and at the same time we may compare its efficacy with the placebo, where we give people some vaccine and the others who they're not getting the vaccine but something else. Phase 3 trial is a much wider study where we give this to thousands of people, and this may take several years to come up with these results. At the moment, as I said, the one which the Russian vaccine, which is again a research institute, they have moved on to the mass production, and soon I think you all heard that President Putin's daughter got it, and he said that she felt fine after it. But this has not been gone through the normal testing cycles, and they've gone on to phase 3 testing, but have bypassed the phase 2 trials. The front runner at the moment is the University of Oxford AstraZeneca, and they are actually at the moment in phase 3. This trial was halted for about a week, a couple of weeks ago, where one patient fell sick, but then the safety board agreed that this trial should continue, and this has since restarted again. The one we are interested in is Sinovac. This is the Chinese company which is leading at the moment in phase 3 trials. They started it in Brazil, and this is probably the same vaccine which we are testing in Pakistan as well. I was reading yesterday that there is issues with people participation in Pakistan because we are skeptical about vaccines, and then traditionally we have been anti-vaccines as regards to polio and other things, and then something like this coming in looking for volunteers. We were aiming to have about 10,000 people in Pakistan participating in this trial, but I think as of yesterday I read that they were having problems in recruiting patients. So now we come to a question where I think if we can answer this, that when will the COVID-19 pandemic end? And I think people have been telling certain things about it, but I think scientifically speaking, there are two endpoints to it. One is an epidemiological endpoint when herd immunity is achieved. And the other is a transition to a form of normalcy, earlier endpoint, which we are seeing at this moment in time around the world and even in Pakistan, where we have come about the initial shock now, and now we are trying to move towards some kind of normalcy. So what is actually a herd immunity? Herd immunity is when a portion of a society immune to COVID-19 is sufficient to prevent widespread transmission. Few numbers have been floating around, but I think the number we all agree is that between 50 and 70% of the population needs to have antibodies against that disease. But you say that now it's enough to stop the widespread transmission. You will still get endemic cases, but the pandemic can stop at that stage. But it depends on many factors actually. And the most important which we are looking at is if we say that the vaccine is something which can bring this up. But vaccine has to be effective and it has to have a coverage. Without that, you won't be able to have that herd immunity. If the vaccine is not effective in evoking the response you need, then the coverage only will not help. So these are two essential factors for vaccine to work. We have about natural immunity also. Globally, about 30 million people have been infected so far, and they have developed antibodies in it. Now, there's a debate about the antibodies as well, for how long they last. And so far, the studies have shown that they do last beyond 3 months. And it also depends on the severity of the disease, that if you have been having serious disease, obviously the bodies will produce more antibodies and you will have a better protection. But the studies have proved that there's still around 3, the antibodies do last beyond 3 months and up to 6 months. So the pandemic is only about 8 to 9 months now. So this is something we need to keep looking about it, that whether the antibody is going to drop or not. We also can look in herd immunity that what is the potential partial immunity being conferred by the other immunizations like BCG vaccines. A recent study in August showed that the countries where BCG is done regularly, and for the last 20 years at least, it compared the countries with the other where BCG is not done, and they did come up with the idea that BCG may provide some kind of a cross immunity for other diseases and not specifically towards COVID-19. The second endpoint we talked about is the transition to a form of normalcy, but we need to remember that this normal won't look like the old one. This earlier endpoint is almost happening now in some countries, including Pakistan. Their life can resume without fear of ongoing extra mortality than usual average achieved through rapid, than to our usual averages. We are always saying that when can we have our things removed, come back to normal and start doing things like air travel and restaurants and going to gyms and school and all those things. And initially the mortality had been very high compared to the normal mortality rate around that country. But I think that the measures, public health measures, and including rapid testing and tracing employed by certain countries, improved therapeutics and supportive care. And we know now, 8 months down the line, something about the disease and strengthened public health responses. This has led to some familiar activities like air travel, though by still not 100%, but slowly getting towards that, and also going towards other activities, opening schools and things like that. But this is something which is being achieved at the moment. Now, where are we in Pakistan in terms of herd immunity and in terms of near normalcy endpoint? I would say we have achieved the near normalcy endpoint at this moment. But have we developed the herd immunity? That is the question. 3 recent studies, which I quote, which have been published and will show in the next slide. In June, around 15.1% seropositivity rate was in Karachi. It increased to about 36 to 40% in June. And then in June, MIH conducted a seropositivity study in Islamabad, and it found that about 14.5% of people were actually seropositive in Islamabad as well at the time. So we can safely say that this corresponds to the Karachi study, and if we say that by now in July or August, this could be around 36 to 40%. I will quote Dr. Shamsi. He said about 2 days back that he has conducted another study, and now he finds that in August and September, the number of seropositivity in his study sample was about 60%. So, with the hindsight, we might say that when we all asked question, when we were predicting that there will be a lot of worst cases coming in July and August and September going forward, what actually happened? This thing might give us the answer that by June we had about 15% seropositive patients among our population, which had increased to about 36 and 40%. And this exactly corresponds with our observation and the facts as well, that this was the time when patients started to decrease, and we saw a sudden decrease in number of patients. Even our own COVID unit, we closed it by mid-July because we had no more patients. And for the whole one and a half month, we had no more patients, and only we admitted few patients in the last week. So this could be one reason where we have been looking for answers, and we said that this could, obviously, alhamdulillah, this was Allah's blessing on Pakistan. But at the same time, I think if you want to look at the answers behind it, probably this was the reason what was going on, that we had about 36 to 40% of our population who had converted seropositive, and with time, it may have crossed 40 to 50%. So these are the 3 studies I was just mentioning. This has been in among healthy blood donors in Karachi. Then the second study was among community workers, and these were factory workers and general population. And the third one from Aga Khan also. This was actually done in April and June, and they compared both the sites, and they looked at a low prevalence area and a high prevalence area, and they did find that the seropositivity had increased in asymptomatic population as well. So I would say that in a nutshell, the way we are seeing second waves in all around the world, the data do suggest that the chances of that happening in Pakistan is less, but at the same time, that doesn't mean that it's not happening. We are seeing some rise in the cases, as I mentioned in the graph there, that in September, in Islamabad only, we had about, we've gone to 25 cases and now it's about 30. But the number of tests is quite high, so I think if we say, we can safely say that we have been steady in that. There have been dips in mid-September and then few cases rise in the next day or so. Although the latest studies and statistics indicate less chances of a new wave of the coronavirus, there is no option of being careless. The virus is very much there. We cannot afford ignoring safety precautions. We need to continue with hand washing, social distancing, and face masks along with PPEs for healthcare workers. Thank you very much.